Yeah. Can we start?
Yeah.
Good afternoon. Welcome to this special World Restart a Heart Day under the Aapi and American Heart Association Alliance. This is a historic day in its own right for a variety of reasons. First of all, this is the first time that American Association of Physicians of Indian Origin and American Heart have joined forces for this great public health crisis. Also, we happen to be in the middle of a pandemic, which makes things even more graver. And this is the first time also that we have trying to highlight this public health crisis in general, but more so in South Asian community. As you all know, cardiac arrest or sudden cardiac death is one of the under-discussed public health crises. All over the world, about 4 to 5 million people die, and I'm sure this is underestimation. In the United States alone, about 360,000 people die annually, and most of them are out of hospital cardiac arrest with very dismal outcomes. Out of all this community, South Asians, as you know, you have heard me and you have read my notes and articles that South Asians are one of the highest risk community for cardiovascular disease, which causes heart attacks, strokes, and sudden cardiac death. I'm sure you heard about sad stories about our own loved ones, friends, and some other close relatives who are walking and doing shoveling snow in the wintertime and having cardiac arrest and not making it up, and those who made it to the emergency room have a brain dead and very poor and very devastating outcomes. Now, just to give you a brief idea, just to rehash, I know most of you understand why South Asians are such at a high risk. Of course, we, speaking in terms of epidemiology, we are about 25% of the world population, but we bear the burden of about 60% of the cardiovascular disease. In the United States alone, South Asians are about 3 to 4 million and have the highest risk for heart disease, something that has been not recognized until recently. Now, why do we have it? Nobody knows. Could be genetic, epigenetic, metabolic, and a combination of all of the above. Some people think this is kind of evolutionary curse because of our evolutionary history, small coronary arteries, thrifty genes, pre-diabetes, and also the lifestyle. So makes a perfect storm for people who have South Asian descent who have come here with that kind of genetic baggage and the epigenetic, stressful, hardworking, competitive atmosphere. The more important question is, what can we do? Now, there are two ways we are handling this crisis at the Aapi level. One is that we have formed a committee for South Asian heart disease, and we are working on two fronts. The one front, which is in the work in progress, is about education, awareness, detection, reaching out, making sure all the South Asians understand the risk profile, especially the ones who have a strong family history, get checked out early, get imaging, and also go beyond the normal protocols and algorithm for detection of coronary disease, including coronary calcium score. And we are going to work on that. We are working on that. But more important, other front is that those who cannot make it, those who have cardiac arrest, how can we improve their survival? And today's day and today's meeting is in that sense actually raise the awareness of factors that play a role in improving the outcomes for someone who has a cardiac arrest at home. So that's where this whole thing is coming. Now, there are some actions taken, something that has happened recently. I want to highlight that American Heart Association has recognized South Asian ethnicity as a risk factor in itself. And that is a late but overdue recognition that Caucasians, Hispanics and Afro-Americans, but South Asians are the ones that never got accounted for in the research trials or registries, to my knowledge. But yet at the same time, we have finally been recognized. We are a small minority. If you read the book, The Other 1% is a very fascinating book. We are the most productive, most hardworking, and most progressive community. At the same time, we pay a price, and the price is higher incidence of coronary disease, strokes, heart attacks, and sudden cardiac death. Now, sudden cardiac death is also very unusual, that about 20 to 25% of people have this as a first manifestation, first and the last. They present as a sudden cardiac death as a manifestation of coronary disease. So they never know why they died. And in this context, it is in this context that today we are combining forces to raise the awareness of sudden cardiac deaths happening in our bedrooms, in our yards, in South Asian community in particular, but all the communities, but in particular South Asian communities. And to highlight this, we have joined the American Heart Association, and I will stop here and I will invite our Aapi president, Dr. Sudhakar Janangada, to give our introductory remark about this alliance and what Aapi is going to do going forward to fight this pandemic at multiple levels, but especially at the level of AHA and Aapi. Sudhakar.
Thank you, Dr. Sharma. Greetings from American Association of Physicians of Indian Origin. As the president of Aapi, I am proud to inaugurate our first ever Aapi event of World Restart a Heart Day program, which is internationally celebrated event in October. This is a special milestone annual event for all resuscitation trainers, volunteers throughout the world from various resuscitation organizations whose hard work and passion are yielding gratifying results in saving precious lives of sudden cardiac death arrest. As you are aware, the aim is to increase awareness about the importance of the bystander CPR and also increase the actual bystander CPR rates worldwide. Aapi is a proud affiliate with the American Heart Association and Indian Resuscitation Council to raise awareness of cardiac arrest for the public in US, India, and elsewhere, to encourage and train the community members as the first responders. As Dr. Brahma Sharma just mentioned, being born as a South Asian itself is increased risk for heart diseases. Unfortunately, if we have a disease before age 50, usually they end up in have a sudden cardiac arrest. I believe that everyone in the family, or at least one person in the family, should know how to resuscitate this kind of cardiac arrest patients when it happens in home, before the emergency medical service reach the home. Aapi salute all the US, Indian, and other international volunteers of resuscitation. We, the Aapi members, are proud to help the global resuscitation program in any way we can. I take this opportunity to commend and thank the leadership of American Heart Association and Indian Resuscitation Council. We're truly blessed by partnering with them. I am sure this is the first time, I mean, it's actually not the first time, we did in the past, but we reconnected with the American Heart Association. We're going to work with several projects with South Asian community regarding heart diseases and probably in cancer. And I'm sure it will help the South Asian community in future. Thank you, and you all have a safe, blessed evening.
Thank you, Dr. Reddy. Let me invite our American Heart Association spokeslady, Francisca Martinez, to make some remarks about this alliance and the future forward.
Wonderful. Hello, everyone. Good afternoon, good morning, depending on where you're located. I'm so honored to be joining each of you today, representing the American Heart Association. Thank you to Aapi for taking part in World Restart a Heart Day today through this event. I'm Francesca Martinez, the National Health Equity Program Manager in the Office of Health Equity at the American Heart Association. And my role within the American Heart Association provides me the opportunity to work internally to leverage diversity, equity, and inclusion for our mission impact. But I also have the distinct honor and privilege to work with national alliances across the country to really advance our mission. Our mission is to be a relentless force for a world of longer, healthier lives, a world where cardiovascular disease is not the leading cause of death, a world where all, no matter your social or economic status, education, race, religion, or gender, everyone has the opportunity to live a healthy life. But we know we can't do it alone. One of our guiding values and principles is powerful partnerships, and that is key to achieving our mission. We cannot be that relentless force in our mission alone. We need leaders, advocates, change agents, and organizations such as the American Association of Physicians of Indian Origin to be that force. As we mentioned, as Dr. Sharma mentioned in the comments, we are in an unprecedented time. 2020 is not the year that we had planned, right? The COVID-19 virus has ravaged and continues to ravage our world and our country, and it has preyed on the most vulnerable, the most at risk in our community. As leaders in health, we have all been tested in this new time. And we've heard the words pivot and reset again and again. They've become our new guides, and many are becoming accustomed to this new normal. We do know that this pandemic has been like an X-ray that has exposed the inequities and disparities in our communities. And like a rallying call, we realize that we must move into action. We must move into action together. And action is no longer a thought for the future, but it has to be what we move into together to be that relentless force. Coming together with like-minded organizations like Aapi, we are going to truly be that relentless force. We will strengthen our voice and we will reinforce our resolve and truly ensure that all have the opportunity to live a healthy life. Together, we're so excited to be embarking on this new partnership to really maximize all of our strengths of our organization in so many ways. Now, you're going to hear more details about that to come. And today, we're already getting started on one of our key collaboration areas in the area of CPR. We know that most cardiac incidents happen outside of the hospital setting, and we have to ensure our communities are empowered with the life-saving skill of CPR. And it is because it's pivotal to both of our missions. Now, of course, we're going to give you more details about the other aspects of our relationship, but we are so, so excited. So again, on behalf of the American Heart Association, we are honored to be collaborating with Aapi to address cardiovascular disease, brain health, and overall wellness, not only in the United States, but in India and to all in the South Asian community. Thank you again to the leadership of Aapi and all who've been working behind the scenes to bring this collaboration to fruition. We are really excited and grateful and definitely look forward to this incredible partnership. Dr. Sharma, I'll turn it back over to you.
Thank you. So I'm so glad, thank you for your comments. I'm so glad you brought up the issue of inequities and minorities. In this special crisis of pandemic, we know more than anybody else, the people who have a disproportionately bad outcomes are the people of minorities. And somehow, pandemic has actually exposed the fault lines. And if you read the news all over the world, it's disproportionately the people of minorities, especially South Asians in UK and Europe, are dying. And some of my commentators and experts tell that the COVID is just an incidental diagnosis. People are much more predisposed to COVID if they have cardiovascular conditions or even adiposity, obesity, the same message that we inherit from our genes or from our environment, from our lifestyle, and the outcomes are so bad. So this makes it even much more important that we take on this challenge in this year because of these multiple factors converging together as a perfect storm. And also I want to point out, just because we have a few minutes, that everybody knows that when people have a cardiac arrest at home, 9 out of 10 don't make it. And it's always the same thing. The household person doesn't know, is hesitant, he doesn't want to hurt, he doesn't know who to call. This has happened in my neighborhood. This happens in every neighborhood, in all the communities, that nobody knows. And by the time the help comes, they are brain dead. No matter what you do, intervene, cath, angioplasty, ECMO, life support, they ultimately die. So the first few minutes are very crucial. I know I'm preaching to the converted choir, but I want to bring it again and again. First few minutes, CPR, hands-only, simplification, and AED in the future can make a big difference. Your survival can triple or double at least. So in this context, I want to invite our Vice President, Dr. Anupama Gotu Mukla. She's passionate about CPR.
President-elect.
put a lot of time and practice in preparing this demo, even though we did not give her too much time. But I am so proud and pleased to have Anupama come and share with us a few words and the video that would be so helpful for a household as to how to start it if unfortunately something happens at home in your bedroom. Thank you, Anupama.
Thank you. Thank you, Dr. Sharma. And thank you, Ms. Martinez, for giving us this opportunity to collaborate with AHA. And Aapi is very fortunate to have this collaboration today, but we'll go forward through with this first start. And I want to thank all my officers and who helped us to spread the message to their families. So there are a lot of family members now in this group. We thought we'll start it with the family first. So I'm an anesthesiologist. So I'm president-elect right now for Aapi. And so as anesthesiologists, we run codes in the hospital. So whenever there is a code blue, we run and we intubate, and so we take part actively in the CPR. But outside the hospital, where it can happen anywhere, in a restaurant, in a movie theater, at home, there's multiple places where we see suddenly someone collapses on the ground and we wait until the EMS comes, but there is a precious time we lose until the EMS comes. So typically EMS is there, paramedics are there in less than 10 minutes in United States, but still that is still delayed. So CPR has to be done within 5 minutes to save the brain. If I wait more than 5 minutes, the brain can go brain dead. So because of no circulation to the brain. So by doing this bystander CPR, we are trying to push some blood from the heart into the brain so that till the paramedics come, we may save that life. So that's why everybody should know this skill of how to do the hands-only CPR. It's a lay person doing a CPR. This is a very simple skill, but if we do efficiently, we can save a life. Nothing gratifying than saving a life. It could be your own family, or it could be your neighbor, or it could be anyone on the street or anywhere. So that's the most gratifying thing if we can save a life. So AHA has developed certain guidelines and we all follow, and the entire world pretty much follows these guidelines. So I think we're going to watch a demo video how to do a bystander CPR. A lay person can do the CPR. So let's play that demo video, and then we can go back and then review, and then have any questions, we can answer all the questions. So let's play the video, Vijaya. Hi everyone, thank you for joining us today to learn hands-only CPR and save a life. My name is Dr. Anupama Gotimukula. I'm ACLS instructor with American Heart Association. And I'm here today to teach you how to learn, perform hands-only CPR, and also learn the importance of CPR in saving a life. Now let us practice together all the way through the discovery of the victim to the arrival of medical professionals. Let's begin. There is a person on the floor. Let's see how he's doing. Hey, are you okay? Are you okay? He's not breathing. He's not responding. Let's call for help. Hey, can you call 911 please? While the EMS arrives, let's go back to the victim and see if he's breathing. If he's not breathing or he's gasping for breath, let's start hands-only CPR. Make sure you are next to the victim's chest with the victim in a safer location. And put the heel of the palm on the center of the chest and lock with the other arm. and push hard and fast in the center of the chest with the rate of 100 to 120 times per minute. Allow the chest to rise back up after every push. If you keep your arms straight as you push, it makes a lot easier. So let's start. Make sure chest moves down at least 2 inches with each push, and don't be afraid to push hard. Good job! The EMS has arrived, and let's take over the CPR. So, thank you for watching that video.
Thank you, Anupama. That was so excellent. Live demonstration. Appreciate your working on it for a very short notice. Now, let me invite a special guest now, Dr. Kapil Parikh. Now, he's special because he has lived this experience of sudden cardiac death. He's of South Asian descent. And I'm so grateful for him to accept the invitation and share his story about life and death. He's like a born again. And not only in that process, he also learned what things can go wrong. I was so impressed when he told me the whole story. I want to invite him and share his story as to what it is to go through this experience of sudden cardiac arrest and how can we improve and how can we go around and make this as an important agenda of our AHA and Aapi. Kapil?
Yes, can you hear me?
Yes.
Yes, first of all, thanks for having me. So what I'll share my story with you and then a few things that I learned along the way. So I'm a practicing urologist, and so several years ago, I had a sudden cardiac arrest in my bedroom. And after almost half an hour of CPR and defibrillation, I did eventually regain a normal pulse. I was very fortunate that I made a very quick recovery. And after a few weeks, I was exercising again and then practicing my specialty a few months later. So obviously, as you know, being a physician and a patient, you start, after such a crisis, you start doing a little bit of investigation. So first, as a patient, I investigated. I went on numerous patient forums, and you know, which was quite revealing actually. Is you go on these forums where other patients, they talk about their experiences, and the first thing I noticed was for a disease that affects several 100,000 Americans every year, these forums only had a few people. For a disease that affects so large number of population, you see very few people that make it to this forum. And obviously the reason is very few people survive to make it to the forums. Most people, you know, obviously don't make it. The second thing that you see is, of all the stories you see, very few survivor stories are from people who survived in their homes. Vast majority of survivor stories are people who survived a sudden cardiac arrest in a public place, such as a school or a gymnasium or shopping center, where there was an AED easily available and somebody could perform immediate CPR. But very few stories of survivors are read in where people survived in their own homes. Now understand that 70 to 80% of people have a sudden cardiac arrest in their homes, but those people aren't surviving. The people that are surviving are those who are surviving outside of their homes. And then the third thing I noticed is, of the people who did survive, majority of those people were left with some sort of disability. And the disabilities were significant that they couldn't go back to work. The most common disability that people experienced was short-term memory loss. which for a lot of people, it was quite debilitating. So those are things that I sort of learned along the way. And then, so what I realized is, what was so different about me? Why did I survive? Because I realized that I was obviously pretty unusual, that I survived, for prolonged CPR in my own home, which is, again, as I said, is pretty unusual. So I had to do obviously a little bit of investigative work to see exactly what happened during that half an hour. Now, to do that, it's obviously a bit tricky. So, but I did get a little bit of help. I spoke to the police officers who came, the paramedics who came, but really the biggest thing was the 911, the dispatch records. Now, the dispatch records, that includes minute by minute, when the ambulance gets dispatched, when the police officers get dispatched, when they arrive, I mean, all the details, but most importantly was the recording. So the entire 30 minutes was actually recorded on a phone, and there was a recording of that, so you could actually hear the entire recording, and I was able to actually put together exactly what happened during that crucial half an hour. Obviously, as you can imagine, there isn't really any experience that can compare to that, to listen to your own, what's the word I'm looking, really to listen to your own code blue, as you can call it, while it's happening. So this is what I learned along the way. So first, and these things, you're not going to read in a textbook. You're not going to read in a newspaper. You're not going to, these things you can only experience and then talk about it. Okay. So the first thing is, the cell phones are a problem, because what happens during a cell phone is that when you call 911, the tower you get may be a cell tower that's located 50 miles from where you live. And the dispatch then sometimes has a difficult time. Now, if you don't give the exact address, if you're off by one letter, one number, then they won't be able to find you. So when my wife, Namita, called, when she found that I was in cardiac arrest, she misspoke by one letter. And for that reason, then the EMS services got the wrong address. So we lost 6 minutes right there. And that actually happens very commonly. That's a very common occurrence, because remember, most people are now not using landlines. They're using cell phones. And if you misspeak by one letter, one number, the dispatch will not get your right address, and your care is going to be delayed. And in sudden cardiac arrest, that's a life or death, that's a life or death difference right there. It's just by giving a wrong number, a wrong address, wrong something. So cell phones, in this particular situation can be a problem. So when the second time when we called, my son called, it was from a landline where they exactly had our address and they knew exactly which unit to dispatch. Now, this is not that uncommon. Since my event, I actually heard about a couple of stories not far from where I live about this exact situation. I'll give you an example. There was a father and son painters who were working in our neighborhood, and father was around 50, the son was in his 20s, and they came from a different county, and they were doing some paint work for a house, and the father experienced a sudden cardiac arrest. The son was on the phone trying to explain where he was and everything, and before the ambulance arrived, it was 20 minutes, so the father died. And this was probably maybe a couple of 100 yards from my house. Second example, again, this was not far from where I live, was a nurse who was in her 40s. Her husband was probably in her 40s as well. She was at home, and her husband experienced a sudden cardiac arrest. And, she's a nurse, so she knew immediately to do CPR, called 911, did all the right things. And she could hear the ambulance coming towards her house, but then the ambulance drove right by the house, because she gave, instead of the street or circle or something, there was one word that she misspoke. And then finally, when the ambulance realized, or they turned around, they came back, it was 5-7 minutes later. And, by that, he didn't survive. Okay. So these are just, you know, so this is actually real. The cell phones in this particular situations may not work. So that's the first thing I learned. And my care was delayed by 6 minutes for that, with that mistake. 6 minutes in this situation, you know, is a lot. So now the second thing is, the first people that are going to arrive in an emergency is not going to be the ambulance. It's going to be a police officer. Okay, because remember, there are 800,000 police officers in this country. There are 50,000 ambulances in this country. So just by sheer numbers, a police is going to be available. Anytime there is an emergency such as this, the police are always alerted, and they are typically, and they are required to respond, and they are going to be the first ones to respond. So in my case, the first person to respond was a police officer, and he responded, you know, the response was pretty quick. So within 10, 12 minutes of it happening, police officer did respond. Now, the problem was the police officer did not have an AED, okay? Fortunately though, the police officer knew how to do CPR. Now remember, by this time, you know, we're like 12 minutes into my cardiac arrest, so it's very difficult to do CPR that by yourself for that long. I mean, you start getting very exhausted after 5 minutes of performing CPR by yourself. So obviously CPR is what saved me here. And fortunately, the police officers, even though they did not have an AED, they did know CPR, so they could carry me along the way. Now, since my incidents, our local police department, they all got AEDs. And in fact, I spoke to one of the officers last year, and interestingly, they, since my incidents, he himself has saved several people because of that change they made. Because of having AEDs in their cars, he himself has saved several people from cardiac arrest because he's the first one that's there. He arrived very quickly. The other story he shared with me was actually a 13-year-old girl he was able to save. So really this change, it should really be mandatory across the country to have every police officer knowing chest compressions and having an AED. So that's the second thing I learned. Now, the third thing is, you know, you talk about an ambulance arriving in 10 minutes, 7 minutes, it's really in theory, okay? Because, and then there's a real world also. And remember, EMS services, they stay within county lines. And if you live at the edge of a county, if you live at the intersection of counties, you know, you may or may not get the closest ambulance to you depending on where you live. So in my example, the county that I live in, the EMS response ambulance was roughly 14 minutes away, okay? But there is actually an ambulance that's much closer, 7 minutes away, but it's in a different county. So obviously 7 minutes and 14 minutes, I mean, that's a big difference, right? So, you know, county lines are a problem sometimes, depending on where you live. And obviously, you know, where you live should not make a difference as to what kind of care you get if you live at the edge of it. And our location was that we actually live in intersection of 4 different counties. So that obviously was a problem. So again, it has to do with your location, the counties, the rules and regulations that go along with that. So then, you know, so then how did I survive and recover? Obviously it was CPR and you can say, I guess you can say divine intervention, I guess. Now, so you understand, so I hope you understand that for someone to survive this situation, everything has to go right. Let's see. So really, so what can you do as physicians? You know, I think the most important thing is, you know, as physicians, which is, I believe, most of our community here today, is that for those who treat the risk factors, hypertension, diabetes, cholesterol, smokers. So if you're treating the risk factors, I think you need to look at the person as a whole, okay? Because why are you treating all these problems? Why are you treating somebody's blood pressure? Why are you treating somebody's cholesterol? Well, the reason you're treating all these things is ultimately to prevent sudden cardiac death. And it really should be mandatory as part of treating these people to just inform them that, hey, why are we doing this to you? And look at the person as a whole. We're doing this to you because we want to make sure that you don't have an early death. And that's why we're doing it. So at least every person who has these risk factors should be informed about CPR, should be informed about cardiac arrest, should be informed about all these things. So I really think, I really believe that it should be a government mandate that as a physician treating all these risk factors, given medicines, giving Lipitor and beta blockers and all these things, at least give patients and their families the knowledge of why you're doing this. Because it doesn't make any sense to treat people with these risk factors, but then not informing them, not informing them about what can happen to them. So I think if you start doing that in about a year or two, you will have majority of the population educated on this topic. And I really think it needs to come from physicians informing the patients when you're treating these conditions, to let them know why you're doing it. Because there's no point in taking Lipitor when you have a cardiac arrest and no one knows what to do. So, as physicians, we can't control much, but I think that's something we can control. And I think that's a very simple mandate that Medicare government can pass. But I do believe that, to survive a sudden cardiac arrest in a home, everything has to line up properly. The telephone call, the response from the police officer, the response from whoever arrives, proper CPR, a defibrillator to arrive on time. I mean, all those things have to line up properly. And even if one of those things is missing, then survival is not possible. And that's why you see in homes, very few people survive a sudden cardiac arrest in their home. The other thing I would say is there are certain logistical things that you don't think about when it happens. It's one thing to do CPR on a dummy and just do it in isolation. But remember, when a cardiac arrest happens, you have to call 911. You have to turn your front door light on. You have to open the door. You have to keep your phone line open. You can't hang up the phone. You have to perform CPR and then just wait for the AED. But there's little things that you don't think about, and that's where patient education would come in. But I do believe that, to truly make a difference across the board, I think that the government will one day have to pass some legislation, addressing the crisis. Until there's a true legislation that's passed by Congress, things like police officers having AEDs, things like everyone being educated on simple recognition and CPR, making subtle changes to the EMS response system. And I believe more importantly in the long run is going to be work towards low-cost AEDs in homes. I believe that that's going to be, I think that's going to be the biggest change that'll come is when you can have a low-cost defibrillators in homes. Because remember, 20 years ago, there was a study in the casinos that if you applied a defibrillator within 3 minutes, 75% of people survived. And in the real world, that's going to be hard to do without having a defibrillator that's very close to you. And I think one of the big problems with cardiac arrest has been that there have not been people who can speak about it. Remember in the 80s, you had Ronald Reagan and Nancy Reagan. that they both had, Ronald Reagan had colon cancer, Nancy Reagan had breast cancer. And that really started the whole screening process. And that's happened with all sorts of other diseases, is you have people who are, you know, who go on to be spokesperson. The cardiac arrest, the difference is that people aren't surviving to be spokesperson, because most people, you know, they perish. So that's, I think, has been a problem, is in cardiac arrest, there have not been any survivors, any famous people who survived and who can come and talk about it, who can be advocates. So I think that's kind of hurt this problem in the past. And one of the problems that I do want to add with the COVID is, I think we're going to find that this year, very few people are going to survive this year from cardiac arrest. Because remember, what we're saying is that people rarely survive in homes. People are surviving in public places. Well, with the COVID, there are fewer people in public places now. So I think we're going to, it's unfortunate, but I do believe that we're going to see fewer people surviving because of the COVID epidemic. And the other thing that I think may happen is bystander CPR, maybe people may be more reluctant to perform CPR because of worrying about catching COVID. So I think that I'm concerned that that may be a detriment to cardiac arrest survival, the COVID pandemic. So anyhow, I want to stop here and answer any questions that you may have for me.
Oh, Kapil, that was so powerful. I'm still getting chills down my spine. It is so nice of you to share and be vulnerable and expose and relate to us. We still have a few minutes. Can you comment on like high profile cases and what is the latest version of AED? It's cheap portable that is coming down the road. You're right, you know, CPR is one step, but in the link of survival chain, I think every household, especially South Asian household, should have one spouse trained in CPR and an AED at the bedside. So please, can you comment for a few more minutes? We have time.
So high profile cases, you know, I will say it was very sad to see this just a couple of months ago. You had the wife of a congressman, Congressman Barr. His wife, she was 39 years old, and she had a sudden cardiac arrest in her home, and she unfortunately did not survive. And again, it's the same story. She had a sudden cardiac arrest in her home. And then we had, you know, we had a few. One thing I do want to comment about that case is when the cardiac arrest happened, it was disappointing to see that the media, you know, they talked about her cardiac arrest, they talked about her death, but there was very little talk about what we can do to help survival in homes. The talk was mostly about the grieving process, which obviously was a big deal, and it was a major tragedy for the family. But then there was no talk about the survival and everything. And I wish when there are some of these high profile cases that there is more talk about what can be done for prevention. And then one of the other high profile cases which was again disappointed to see, was which is really, I would say, is the most famous cardiac arrest, I would say, in history, was George Floyd. The gentleman who died in, it was because of, you know, police brutality. But if you watch the video, you see that he actually had a sudden cardiac arrest. You could see in front of your eyes, he had all the risk factors, and he lost consciousness right there. And it was not recognized by the police officers. It wasn't recognized. And even when the EMS came, rather than performing CPR on the spot and giving him defibrillator, he really did not get CPR until 9 minutes after he lost consciousness. So that really, you can just think how history would be different today if George Floyd had gotten immediate CPR defibrillation by the people around him. But, you know, unfortunately that did not happen. And that's because people around him did not recognize that he had a sudden cardiac arrest. He did not get the proper treatment, CPR and defibrillation that he needed immediately. And if that it's all on video that you see, that was pretty unfortunate. But I would say that's probably the most famous cardiac arrest that's ever taken place, and that has had the biggest impact in this country. And then there have been others, but as far as the low-cost AEDs, I would say that I know there are companies that are developing them. There's one company in particular in California that's starting to develop them, and they're trying to make them very user-friendly where very little knowledge is needed. So it's basically you turn it on, and as soon as you turn it on, it actually connects you directly to the 911 dispatcher. So you don't need to worry about that phone call calling 911 and everything, and it actually connects you directly with the dispatcher while you're performing CPR, while you're doing the defibrillation. And from what I'm hearing, the cost of these is going to be much less than cost of an iPhone. But we'll have to wait and see.
Thank you so much. So now we will open up this panel for question and answer.
Brahma, I think Gunjan is on. Introduce Gunjan, please. Dr.
Okay.
Gunjan.
Welcome. Let's welcome Gunjan. Gunjan Shukla is electrophysiologist and expert into sudden death, and we appreciate his coming on board to help us on a very short notice. Gunjan, please join our panel for question and answer session. And Kapil, also hang around. People may have questions directly for you. So let's get everybody on board, and then we will follow the chat room to see if there are questions coming and go one by one. Anybody has any comments or anything, feel free to say something. We still have 5-10 minutes.
So while Dr. Gunjan Shukla is coming on board, that was a moving presentation, Dr. Parikh, and really brought tears into my eyes, as well as many of the audiences here. It's really going to make an impact on all of our lives. We're going to get all our family members trained, make sure we're all safe. Thank you so much again.
Thank you.
The panelists are ready to question and answers? Gunjan and Brahma and Pratik?
Yeah.
Okay.
Yeah, I'm ready. Thank you very much for inviting me. I'm one of the cardiac electrophysiologists, and in a daily life, I see a lot of patients with cardiac arrest. And I don't know, so far it has been mentioned, but there are a lot of famous cases, like starting from Reggie Lewis in 1993, when he was a famous basketball player who dropped on the court while having a basketball practice, and he had a sudden cardiac arrest. He was seen actually by my teacher, Mark Josephson, in Boston, and he was advised not to play. But as you know, basketball is a very competitive sport, and he had a form of cardiomyopathy that can have a sudden cardiac arrest, and ultimately he died while playing basketball. So it's a deadly disease. Early intervention is very, very important. There was a nice study done in Seattle where they trained regular citizens to do CPR on the people. And they demonstrated that actually by training the regular citizens in doing CPR, you can actually double or triple the survival rate of cardiac arrest. So timely CPR is very, very important in a cardiac arrest. Once you lose several minutes, brain becomes dead. So even the body survives, the brain may not survive. So it is a deadly disease. And unfortunately, I have to see all of this everyday basis. I'll be happy to answer any questions if people have.
For the first question to the panelists, this is a difficult question. If someone cannot perform CPR, is there any equipment that you can keep and use when needed? Yes. Any panelist?
So there is actually the automatic CPR machine is being developed, and there are many EMS is using it. I don't think it is available everywhere, but that can deliver automatic CPR on the patients while they can get an IV line or get another medication into the patients. But it is being developed for them.
Somebody asking, can you share the recording of the CPR? Definitely, if you can log into aipiusa.org and you can able to see the recording what Dr. Anupama did this afternoon.
It's also on Facebook Live. You can replay it. I put the link on the chat too.
Yeah.
So
Questions?
there is a question asking the CPR is done on the left side, right side, or center of the chest. So like if you have, this is a mannequin, I just wanted to, like the nipple line in the center of the chest. That's where you put the palm and lock the other palm and then give the compressions. So like we showed in the demo, like we have to have at least 2 inches down into the chest, and otherwise it won't be effective CPR. So if you do to the left or to the right side of the chest, it's not going to give you the exact compression where you can pump the blood. So the main goal is to pump the blood to the brain. So if we don't perform that efficiently, then our efforts will go waste. So that's why we are here to train, like we are trained to instruct. So that's where it is, like you push the chest on the center, right at the nipple line. So male, female, all same. Thank you.
Yeah. I have a question to the panelists.
You can type your questions in the chat box.
Yeah, to the panelists. The one of the Indian gentlemen is in 40s, and he's a vegetarian. He exercises pretty good, a very healthy lifestyle. Develop a shortness of breath, and end up having 2 stents. See, the reason why it is a hypothetical question, okay? Because we all think exercise, diet is very important to prevent heart diseases. So what went wrong here? Is it South Asian, because it's South Asian, or any other things we need to look into that?
So can I take on this question?
Yeah, go ahead.
So, the South Asian heart disease is kind of unique. And these conventional risk factors that we know and the algorithm and risk factor calculators are based on thousands of people from Framingham, Massachusetts in the original, 70, 80 years ago. Later on, subsequently, they were modified, but never have been integrated with the risk profile of South Asians. So just because you have a diabetes and hypertension and South Asian vegetarian, the best way for South Asians to detect this coronary disease is by some kind of imaging, and that is a calcium score. Because no matter whether it's genetic or epigenetic or diabetes, the calcium score is the ultimate test that would give you a plaque burden, especially somebody with a family history. Now, this vegetarian idea is a misnomer. The vegetarian diets are actually most pro-atherogenic diet, in my opinion. The best diet that has been advanced is a plant-based diet or a Mediterranean diet. I, usually when I talk, I give an Indo-Mediterranean combination of both, but vegetarian diet is not an immunity from coronary artery disease. But just because you are exercising and you are fasting and God, temple going and all that, best way to detect a coronary disease atherosclerosis early on in South Asia, in my opinion, is to get a calcium score. That will give you, no matter what is the pathway, inflammation, genetics or epigenetics, if you have a calcium score, you will know where you are in your lifeline. It's like anything else, prostate or breast cancer, you do breast imaging. So now there's a new thinking, and American Heart Association has recognized that in people who have a family history, people with a South Asian descent, where it's not clear, it's best to get a calcium score and then stratify your risk and be very aggressive. So that's my take on this.
Thank you.
That's a very good elaboration. I just wanted to add a little bit on to it. That the coronary disease is not what we think. Previously, when the coronary disease started, we thought that you have a progressively higher stenosis, say 70%, 80%, 90%, and then you get complete blockage. This is not how it happens. Most of the acute heart attack happens with the 40 or 50% stenosis, and there is a plaque rupture. what happens, the thin cap of this plaque ruptures and releases thrombogenic material inside the blood vessel, which causes an immediate clot formation and causes acute ST elevation MI. So what happens in people with South Asian descent who have a really genetic history of coronary disease, those people do have those small plaques, which is asymptomatic, 40 to 50% plaque, which would not be giving you any symptoms. But the cap of this plaque ruptures and that causes an acute ST elevation MI. So this is an inflammatory process rather than progressive increase in the plaque, which also happens up to a certain extent. But this kind of heart attack at 40 years of age usually happens with the plaque rupture. And that's what we have to, and sometimes there is no way to predict it.
Is that what explains a lot of these marathon super athletes dropping dead while they're...
That is one of the things, but many of the super athletes, like when I talked about Reggie Lewis' case, he had a hypertrophic cardiomyopathy. So that's a different cause of cardiac arrest. So cardiac arrest, coronary disease is just the one component of cardiac arrest. There are a lot other diseases, which is long QT syndrome, hypertrophic cardiomyopathy, short QT syndrome, polymorphic ventricular tachycardia syndrome. You have a CPVT, catecholaminergic polymorphic VT syndrome. There are a lot of congenital heart diseases that can cause cardiac arrest, totally asymptomatic people. So the coronary disease is one of the most major culprit in America, but there are other diseases also are very prevalent.
So I agree with Gunjan. Just want to add that in young athletes, number one cause is hypertrophic cardiomyopathy, and number two is anomalous, unusual origin of coronary arteries from different orifice, and they get compression and they start isolating. But in an out of hospital cardiac arrest, number one cause, as Gunjan said, coronary disease unless proven otherwise, 70 to 80%. The question about giving aspirin before the CPR, I don't think that makes any difference. Let us not waste time in aspirin. When there's a CPR, there's an opportunity to jump in. Two-step process only, as Anupama said. Call for help and start 1, 2, 3, 4, 5. That's it. No breathing, nothing. In this COVID age, nobody wants to do mouth-to-mouth breathing anyway. So just two-step process until the help comes. And the help should be in the household itself. That's the whole point. And hopefully we can have an AED when it gets a little cheaper. So if you have a CPR from the household and AED, you have the best chance of making it.
So the sudden cardiac death and acute MI are two different phenomena. The aspirin probably helps the acute process, not the SCD. Is that what the take-home point?
Well, the thing is that if you are in a sudden cardiac arrest, the patient is not actually awake to give the aspirin. It will go in the breathing tube. So there is no point of giving aspirin because patient is unconscious. You can't give unconscious people, have them take a pill. It's not possible. If it is patient is conscious, then it's possible. So it's a two different thing. Acute MI can cause cardiac arrest, but acute MI is not a cardiac arrest.
Right.
Yeah. Another question is, why women are more prone to heart diseases? What extra precautions women should take to prevent this?
Go ahead, Gunjan.
Oh, I can go, but so women, so there is a coronary artery disease behaves a little bit differently between men and women. Men, it can actually start from their 30s. And the women usually start after their menopausal years because somehow natural estrogen protects them from the coronary disease. But in America, if you look at it after menopause, they catch up with the men very quickly. So that's why you may be seeing a sudden increase in a coronary artery disease after menopause in the women. So that may look like that they are more prone to the heart disease, but heart disease actually is more common in men and it starts very early. So I have seen people having 25, 30-year-old having an acute MI. Sometime there is drugs involved like cocaine, which are very sympathognomomimetic drugs and can cause acute coronary spasm and can cause heart attack. Sometimes there are some weird diseases like called Takotsubo cardiomyopathy, which women are more affected. Like say, if the husband dies, then women goes in an emotional shock that can cause sudden cardiomyopathy and cardiac arrest. So those kind of things are, so there is a little bit difference between men and women, but I think they're prevalent in both men and women.
Thank you. Question to Dr. Brahma Sharma. Role of statins in the prevention of sudden cardiac death.
Yeah, so the statin again, like, you cannot wait for the last minute to give a statin. Everybody from age 20 onwards should have a lipid profile. And then more and more data are coming that from 20s and 30s and 40s, that is the best time to intervene. And regardless of the lipid profile, if they already had an element, depending on the lipid profile and calcium scoring, statins are the way to go. So I recommend statins on 20s and 30s, there were familial problems, but for all the people and for primary prevention, statins are the best drugs so far discovered to reduce the incidence of heart attack and subsequent cardiac arrest. As Gunjan, Dr. Shukla said, the coronary disease has two parts. One is stable syndromes, stable angina, stable heart disease, but there's an unstable part of it. We call it acute coronary syndrome, which can cause a non-STEMI heart attack, a STEMI heart attack, and consequence of that, there's a irregular heartbeat, tachycardia, ventricular fibrillation, which we call in layman's terms of cardiac arrest. So statins prevents all of that, all the way.
Yeah, but the Dr. Sharma question, there is people are talking that statins can cause diabetes, statins can cause kidney problems. Can you answer that question for me?
No, there is that later data showed that there is no really incidence of dementia or kidney disease. And there is just some incidence of pre-diabetes, but the risk and benefit ratio still favors statin therapy.
So you suggest use statin then?
Yes, I take it myself, even though I don't have a family history.
Okay.
Everybody with a
Thank you.
profile, and especially with the high calcium score in South Asians, would be on a statin. Now, aspirin we can discuss later because that's a little controversial.
Okay, there is another question. This is nitroglycerin. Patient is not on, regarding nitroglycerin, make sure patient, I don't know who is talking this. Okay, don't worry about that, yeah.
So what about how young you can see these sudden cardiac deaths, like children, especially if they have congenital heart diseases or abnormal vasculatures or myopathy? What's your experience of?
The kids are prone to have a cardiac arrest, but the incidents are less. But there are some syndrome we are discovering, which is called catecholaminergic polymorphic VT, short QT syndrome, long QT syndrome, that can present with the what we call it. Pediatricians call it SIDS, or a sudden infant death syndrome. So one of the component of sudden infant death syndrome, or SIDS, it is related to cardiac arrest, and those are usually congenital heart disease, as kids don't have that much coronary disease. Some kids may have, like Dr. Sharma said, about anomalous coronary arteries, and sometimes they can develop this kind of sudden cardiac arrest. But it is seen in the pediatric population. I was trained in Boston, and we used to have a very busy children's hospital and a pediatric EP program, and I've seen kids having a defibrillator implant for a sudden cardiac arrest. So it is well seen in the electrophysiology community.
So most of the high school athletes and soccer kids do get some kind of physical clearance, right, before.
So actually, if you look at in Europe, like say in Italy, if you want to play soccer, every kid goes extensive cardiovascular evaluation, including EKG and echocardiogram. Over here, unfortunately, we don't do it at a kid level, but like say my partner is a Giants cardiologist, and we routinely go to the Giants stadium to do their echocardiogram and EKGs. And many of these big players, they do have a hypertrophic cardiomyopathy, and we may have to take them out from the competitive sports. But and in the future, I think we should be screening all the kids before we can have them play competitive sports, basically.
Yes.
Dr. Sharma, question regarding statins.
Yeah.
Do you recommend any statin better than other statins, or all statins work same?
They all basically are the same, but for people who present with acute coronary syndrome, like acute angina or non-STEMI or myocardial infarction, we prefer the Lipitor because that has been studied the most. And Lipitor and statins, I just want to emphasize, it's not about lowering your LDL. The cholesterol are three types: good, bad, and ugly. The bad cholesterol, I'm sure I'm talking like this because there are some lay people also in the audience. So LDL is the bad one. And the statins not only lower LDL, but we have to understand there is another mechanism of statins, and it's called a pleiotropic effect, which means, just like Gunjan said, inflammation. So not only lowers the LDL, but also reduces the inflammation and plaque rupture and all those acute catastrophes. So statins work by LDL and by non-LDL pathways also, but that's the way to go. That's the best medicine for preventive therapy so far discovered.
So you think atorvastatin better than rovastatin?
They're both equal, but my personal preference is Lipitor, atorvastatin, because that has been the best literature.
Okay.
Secondary prevention.
Thank you.
Primary prevention, you can go with anyone that you can tolerate. And some of them have different metabolic pathways, and then you can go depending on one which tolerated. But the best studies and best data are on these statins. First was Zocor, then Lipitor, and then Crestor. But it's a semantics, basically. Be on something, not only for your numbers, but also for reducing inflammation, especially if you have a family history and a positive calcium score.
Okay. So another question, what is the role of triglycerides? And will statin help to?
Yeah, they were not thought to be a risk factor, but lately they have been recognized as an important risk factor. We do know that, despite our best efforts, there's still a lot of percentage, 50 to 60% of people, statins only reduce about 30 to 40%. We still have a residual risk. So this word called a residual risk is despite being on statin, aspirin. Why are people having heart attacks? Why the risk is not zero? That's where the residual risk comes. And they have been realizing that the triglycerides are the culprit, second culprit, second in command. And there's a new drug just came out, Vasipa, and that is the best drug that has been studied. Unfortunately, they lost a patent battle, but Vasipa or very sophisticated, fish oil can do it. That's the only medicine that has been shown to reduce the outcomes. So yes, it plays a role.
I agree with you. Fish oil really play a good role because I use my patient with lipidemic pancreas problems. The fish oil works very good for high triglycerides. Thank you. I think there are pretty much questions in the
diastolic hypertension risk factor. Yes, hypertension, systolic or diastolic, both are bad. Systolic is more than diastolic. Yes, and hypertension is number one in terms of risk factor for coronary artery disease, more than diabetes, more than hyperlipidemia on a global scale.
All right.
Next question is, can you give nitroglycerin in RVMI? No. Right ventricular infarction, involves the proximal coronary artery dominant. And as you know, right ventricle is a preload. That means you need some volume in the body to maintain your blood pressure. And if you give a nitroglycerin in the ER, you will pass out. Actually, this is one of the board questions. Somebody came with an inferior MI, had a chest pain, got a nitro, and he bottomed out in the ER. So you can always say right ventricular infarction because they are preload dependent. You need some volume. So people with the RV infarction, please start that saline drip, fill the tank, and then that way they can continue to have maintained the forward output. And don't keep giving them nitroglycerin. Otherwise, you will have a shock condition right in the ER created by you, iatrogenic shock.
Gunjan, question to you. The statin dosage, is any optimal level for older people, statins?
So statin is, I just wanted to recap with Dr. Sharma said why Lipitor is the best one because it has been best studied. They actually looked at the carotid artery plaques with the Lipitor. And basically what Lipitor does that, as I previously said, that the acute MI happens because of plaque rupture. So it makes that.
Gunjan, there are a lot of non-medical in this group. Okay, so you are discussion should be that level. Okay, thank you.
Sure. No, I will. So what it does that it actually makes the cap of the coronary plaque very thick. So it doesn't let it rupture, and that's how it reduces acute MI. How much dose should be given? The dose studies was 80 milligram of Lipitor, which was the highest dose available. But there are some people may not able to tolerate that because of myalgias and other side effects of Lipitor. So in my practice, what I would do, I would titrate it to the highest dose, which is tolerated by the patient. And I would go as high as possible. So for 78-year-old, there is not like something which is what is the highest dose. You can still give the highest amount if they are tolerated.
What do you mean tolerance means?
So
muscle cramps?
Yeah, so some develop myalgia, muscle cramp, fatigue. Some people have even a higher level of muscle breakdown, and then you can have a enzyme leaking in the blood and stuff like that. Those are the higher problems. But many people do develop myalgia and muscle cramps, so we may have to back off a little bit.
Thank you. Why Bacall removed from statins?
It was at a toxicity. So it was a statin, but it had a lot of problems, so it was taken off. Now, next question is LPA. Oh my God, anything for LPA that is close to 300? 300 is very high. There's a question from Bansal. 300 is very high. LPA, I'm glad you brought it out, is another risk factor, genetic, which should be monitored and checked in people with a family history. And 300 is very high. And there are new drugs coming out for LPA. But right now, the best treatment for LPA is bringing the LDL down. The statins don't do anything about LPA. The fibrates don't do anything that helps the LPA bring down a little bit is niacin, which we cannot tolerate. So that's why.
Excellent.
Another question is HM. No, they do not cause long-term damage. That's all myth. If the liver function tests go abnormal 3 times the normal, then you can stop or cut down the dose of HMG reductase inhibitors and monitor. Yes, there are some studies on South Asians on cholesterol, which have shown the same effect, same benefit as the Caucasians.
Any studies on cholesterol in Indians in USA? That's a masala study, right? The masala.
Masala is not a statin study. Masala is an epidemiological study. We South Asians don't have Framingham type of long-term studies. So Dr. Alka Kanaya from Chicago and some people with her have done for the first time a prospective South Asian registry data to have actual information on us, because most of the time we extrapolate from other ethnicities. So that is a remarkable landmark study. One of these days we will invite her to give a talk, and then she can give us update on masala study. There's one study in England also, lollipop study, and one here masala study. These are the 2 studies that I know that are primarily for South Asians, first authentic long-term epidemiological studies.
Yeah. A question from Ashok Batra. What is the ideal blood pressure to maintain?
120/80.
Okay.
Hypertension guidelines have been changed. So 120/80 is normal. 120 to 129, we call it elevated blood pressure. And above 130, hypertension stage 1. Above 140 is stage 2. And the reason they are calling stage 1 is stage 2 is to instill fear in us, just like a stage 2 malignancy or stage 2 cancer. The terminology has been changed to manipulate our psychology. So right now the hypertension is stage 1 or stage 2. Anytime your blood pressure is 149, you're stage 2. Bad news.
Yeah.
It is again an excellent summary of all the risk factors and mitigating factors. And any other questions? I think there are a lot of chat. Anybody is monitoring it?
Yeah, I'm doing it, Ravi. I think they're pretty much answered though. They did a pretty good job.
Dr. Parikh, any comments on what you heard from the cardiologist, or two of our best and the brightest cardiologists?
The final comment. You have the final privilege of closing this up with the final comments. Kapil, go ahead. I think it's mute.
Yeah.
Dr. Unmute you, yeah.
Yeah.
You can unmute yourself.
Okay.
Yeah,
Can you hear me now?
Yeah.
Yeah, no, I don't have any comments. Thank you for having me. And I just hope I was able to give you a little bit of insight. And hopefully there will be improvements made in the future to improve survival. And that's all we can hope for.
Thank you, sir.
You want to say thank you very much. Thank you. And Dr. Brahma, you want to say what are thanks? And
yeah, so again, thank you for joining on this busy Sunday on a short notice. I really appreciate, but this is something we had to do, we wanted to do, and I'm so glad we did it. And this is just a beginning. We'll build on it. We will seek the partnership of like-minded people, especially American Heart Association, and with Sudhakar's leadership and Anupam and Ravi, we want to branch out and give this message to all the chapters and build on this so we can reach out every household, not only South Asian, but every household, but mostly South Asian household where everybody knows what is our risk. Everybody has some kind of CPR training and an AED eventually to minimize and risk of this unnecessary death in South Asian community. As we have to, our race, we are the one race where our race becomes race against time. We are blessed in one way, but we are cursed in one way. So let's work together.
Thank you, everyone. And have all blessed days. Stay safe. Bye-bye.
Thank you. Thank you, Dr.
Thank you.
Again.
Thank
Bye,
you.
everyone.
Thank you, Ms. Martinez.
Thank you, Anupama.
Thank you.
Thank you, Brahma.
Bye.
Thank you.
Thank you,
Thank
Ms.
you.
Martinez. Thank you.
Bye.